Thank you for joining us on Wellness Monday. November is National Lung Cancer Month, and I am thrilled to have with me my guest, Dr. Tiffany Schatz. Let me tell you a little bit about Dr. Tiffany Schatz. She is the owner and founder of Lumiri Surgical. She grew up outside Philadelphia in Kennett Square. She earned her undergraduate degree, magna cum laude, at Messiah College. She then attended the Medical School for International Health at Ben Gurion University in Beersheba, Israel, where she studied medicine as well as cross-cultural medical care with emphasis on international and resources poor settings. She then moved to Waterbury, Connecticut for residency in general surgery at Waterbury Hospital, affiliated with the Yale University School of Medicine. She then trained in minimally invasive thoracic surgery, including robotic surgery, at Fax Chase Cancer Center, affiliated with Temple University. Dr. Schatz is trained in advanced minimally invasive approaches with laparoscopic, thoracoscopic, and robotic procedures, as well as minimally invasive workup of chest masses, lymphadenopathy with EBUS and endoscopy, bronchoscopy. She loves taking care of her patients during a time in their lives when things are uncertain or frightening in the setting of illness and need for surgical evaluation and treatment. Again, Dr. Schatz's practice focuses on lung cancer and chest masses, paraesophageal hernias, esophageal and GI complaints, palliative surgery, as well as evaluation and treatment of general surgical problems, with a special focus on problems that affect the chest, such as substernal goiter. She is board certified by the American Board of Surgery. Dr. Schatz also maintains her membership in the American College of Surgeons, the Society of Thoracic Surgeons, and the American Medical Association. She's worked in the past in the DMV area in Maryland for her first years of practice, then relocated home here in the Philadelphia area and lives with her handsome husband and three beautiful children. Without further ado, we're going to talk about today in our topic, and so I'm welcoming Dr. Schatz. Hi, Dr. Schatz. Good morning. How are you?
Thank you. I'm very well. How are you? Thanks for having me.
Thank you for joining us. Um, I thought, with your area of expertise, and especially since in November is National Lung Cancer Month, it's a perfect time to, talk about, the benefits of lung cancer screening. And I wanted to chat to you about, what are they, in that part of lung screening in the sense of low dose CAT scan lung cancer screening. If you can expand on that a little bit.
Of course. Lung cancer is the number one cancer in the country for both men and women, the number one killer. It is more deadly than breast cancer and colon cancer. And so it's a big problem. Now, about 10 years ago, this low dose CT scanning was evaluated as an option to decrease risk of death from lung cancer. And so it was found that actually this lung cancer screening decreases the risk of death from lung cancer by 20%. So essentially, if one is able to catch a lung cancer early, it is able to be treated and effectively and hopefully with a cure, which is better odds of curing cancer than our other screening tests, including mammography, pap smears, and colonoscopies that help us to assess for those other common cancers.
Now you mentioned both men and women, so let's talk about who should get a low dose CAT scan for lung cancer screening, since you brought in both genders in the
Right.
population.
Lung cancer screening is available for people with high risk, and those people are long-term smokers. So that is a population that it was evaluated in for the initial studies for its effectiveness. So initially, the rule was 30 years of smoking, a pack a day, or something that was comparable, such as 15 years of two packs a day. And
Right.
now It's anyone who is older than 50 years old who has smoked at least 20 years or 20 pack years. A pack year is basically smoking a pack a day for 1 year. So you could smoke half that for double the time. It still equals the amount of smoking injury to your lung.
Oh, wow, that's very interesting. So so from that age bracket and how you're describing it, if you actually had at least smoke in those time frame of years, you can avail yourself to a low dose CT lung cancer screening.
Right. And this is a test that's covered by most insurances and Medicare. So as long as you meet that criteria, you are appropriate for lung cancer screening yearly after age 50.
Now, are there any risks undergoing, the CAT scan, just in terms of, the thought of, radiation or things like that? Folks are a bit sensitive in that area. So would there be anything?
The risks are quite low. We do use a lower dose of radiation for the lung cancer screening. That's why it's called a low dose CT scan. And so when you measure the risk, that's why there is eligibility criteria for people who have smoked, who are higher risk. So then we balance out the risk of the test itself with the risk of developing the cancer and reducing the risk of dying from that cancer. Now, you think about that also with our other types of um, cancer screening tests. Radiation is involved in mammograms. You have, colonoscopies. It's an invasive procedure, just like pap smears are somewhat invasive, although much less so. And so those all have some kind of level of risk, but we balance that with the risk of actually dying from the cancer itself.
So for our audience out here, if there's any questions that you may have, please pop that in the chat, and we're going to come to our question and answer for a few minutes that we may have left at the end of our session. So please, I encourage you to do that. Pop in your question. So what can a patient do to reduce their risk of developing lung cancer? And I think, I think about the smoking and, how smoking is seen, right? As early as sometimes teenagers, and as you grow, and the sophistication that sometimes is associated with you smoking and the images and things like that. I think that most of us that have grown up and seen that, you think about what are some of the ways that we could reduce that risk, and and be not smoking, or not engage in smoking, or lean towards not taking a cigarette, if you will.
You're exactly right. Smoking is the biggest risk for developing lung cancer. And so, not starting smoking is obviously the best option. But if you are already smoking, you do reduce your risk of developing lung cancer by stopping at any point. And the longer that you don't smoke, the lower your risk is over time. And so that is positive news. People have all kinds of reasons why they smoke and why it's hard to quit smoking. For example, some people use it to help them control their weight because it's an appetite suppressant. Some people, a lot of people that I know, many of my patients smoke because it helps them manage their stress. Because they either it's the habit helps or the chemical itself. It's just there's something comforting about it. There's something familiar about it, and so it makes it very difficult to stop smoking. And finally, one thing that is difficult is when other people in your household are smoking. So if your husband or wife is smoking, your daughter, your parent, then it makes it very difficult to quit. So the advice I have is to manage those other risk factors. Find new ways to manage your stress. Quit with your family members or with your friends. Be a support group. Decide that it's important enough to help each other improve your health by quitting smoking together and being your best advocates for each other. And so those are the main things that I would recommend. Other factors that are involved in risks of lung cancer, including chemicals that you may be exposed to at work, or asbestos, which is a more of a previous
Mm,
risk, are definitely things that can be managed but are harder to manage as individuals. So smoking is our best bet to reduce. Now, as far as people getting lung cancer who have never smoked, you
mhm.
anybody really can get lung cancer, but smoking substantially increases your risk.
Is You mentioned that if you never smoke, but yet, other family members are in the home, is that the consideration of like a second-hand smoking exposure in the home,
Right.
so to
Secondhand
speak?
smoke
Or
can be significant to increase your risk, especially if it's heavy exposure over a long period of time.
mm,
That isn't exactly what I was referring to. Even people who haven't been exposed to smoke can get lung cancer, and so I think it's important to be aware of that because your risk isn't zero, even if you've never smoked.
I see. So it's best to make sure that you get the annual, knowing that insurance payer plans are covering that. And you mentioned, Medicare. There are some, commercial payers out there that are covering that also. And so uh, as an ounce of prevention, I often say, it's good to have, your annual checkup, right, for everything that you're closing your care gaps. And as those are just one of the things that should be part of your checklist. So let's say a patient, is being referred to you. They're recently diagnosed with lung cancer. What is your evaluation process? How do you, walk through the patient in terms of, from talking with you, and what are some of the things that the patient should be bringing once they're referred to you? Things that are going to make the office visit productive, and have that conversation with you, and know more about what their treatment plan would be, and so on.
Right. So, as a lung surgeon, I often am sent patients who already have quite a bit of their evaluation and diagnosis. As far as diagnosing lung cancer, the first thing that we typically do is CT scan, imaging that shows the mass or growth there in the lung. And that's usually done before patients see me. So
Hmm.
I would need those images to be brought either on a disk or some kind of login so that I could take a look at them. The next step is for diagnosis. Typically, for lung cancer, we do a biopsy for diagnosis, and that is often done using a CT scan guided biopsy. So, a patient is typically brought into a hospital environment, and a radiologist uses the CT scanner to localize the nodule or the mass and takes a sample of it. Sometimes
Hmm.
that's done before patients see me. That can be very helpful. Occasionally, before that biopsy is done, a PET scan is ordered.
Hmm.
A PET scan is part of the evaluation for staging of a lung cancer.
I see.
A PET
Okay.
scan is often thought of as a cancer scan, but it is
Hmm.
not specific to cancer. It more shows where there's tissues that are growing rapidly,
I
which
see.
are definitely cancers are in that category. Sometimes we'll also see infections where there's a lot of
Mhm.
inflammation or other kind of immune processes going on. But when we're concerned about cancer, PET scans help us to know if that lesion is actively growing, and if there's any of that tissue that has spread to other places, such as the lymph nodes in the middle of the chest or to other areas in the body, which would be called metastases. So those tests are really critical for evaluating lung cancer. The next, and oftentimes patients will come to my office with those things.
Okay.
Whatever testing has been done, I do appreciate patients bringing to the office so that I can review it myself. Reports are helpful, but the pictures are worth a thousand words, right? So I can make
Absolutely.
a plan for operating when I look at the images myself. The next step in evaluating patients with lung cancer, especially prior to treatment, are another another study that helps us to evaluate for spread of the cancer is an MRI of the brain. So especially if
Mm,
the mass is large or the biopsy
mhm.
is positive, we typically get an MRI of the brain to ensure that there's no spread there. Now, the
Okay.
reason that we need an MRI in addition to the PET scan is the PET scan shows uh, the brain being very active because it's taking up
Mm,
a lot of sugar. So it doesn't help us to know if there's a cancer spread there. So we need another
gotcha.
test for that. And then finally, before a patient can undergo any kind of treatment for lung cancer, whether it's surgery or radiation, we need
Mm,
to evaluate the lung function. So
mm,
typically, a patient is seen by a pulmonologist or their primary care doctor sends them for pulmonary function tests. And these tests help to show how much of the lung is available for a patient to use day by day. Amazingly, each and every one of us are born with more than enough lung tissue to survive.
mm.
And over the lifetime, often with smoking or other medical issues, that lung function is reduced. So, by knowing how much the lung function is available, we can evaluate how much of the lung can be removed, for example, in a lung cancer surgery, and then the
Mhm.
patient would still have a relatively normal lifestyle and life expectancy afterwards. And so doing all of those tests help us to evaluate for surgical care. If any of these pieces are not done prior to the appointment with me, I would certainly go ahead and order them. But if they are done, then they can be brought to me and we can make a surgical plan from there.
So, from what I heard thus far, is that if they start off with tests that are such as low dose CAT scan and they've had PET scan already performed, they can bring that about, bring those images. The reports are very helpful, and then then the next step would be after, an MRI of the brain when needed, and then that all is going to be encompassed with your consultation, and then we'll have the conversation. Is there any blood work perhaps or anything like that that would be needed, or as they are a surgical become a surgical candidate after they've had your consultation? Would there be something like that, just out of curiosity?
Right. So anybody who I take to the operating room, I do obtain blood work to evaluate their blood counts, to make sure that they're not anemic, to assess their kidney and liver function before undergoing anesthesia. And so those things are a very typical preoperative evaluation.
Okay.
Additionally, I would send the patient for a cardiac evaluation with a cardiologist to check the heart function. A lot of times, patients who have been long term smokers also are at high risk for cardiovascular disease,
Hmm.
atherosclerosis, and at higher risk for heart disease with heart attack and stroke. So, I want to evaluate patients for those risks before taking them to surgery so that we can make sure the patient comes through as safely as possible. And sometimes the cardiologist or the heart doctor will order additional tests to make sure that the patient is ready for surgery.
So what out of curiosity, what brought you to your focus on lung cancer? As your specialty. I know you have other areas as well, but just out of curiosity, you're focusing in that area.
There are a lot of things that I like about taking care of patients with lung cancer. Um, I think partly removing the cancer to have a possible cure of cancer is very rewarding. And doing lung surgery is beautiful. So the anatomy is beautiful, and it's beautiful to be in the chest where the heart is beating, and a lot of the major blood vessels for the body are there. It's it's a really wonderful and awe-inspiring kind of surgery. Um, so I do feel that it's a critical surgery. It is high risk, and I want to be there for patients who are undergoing this kind of care. Um, so one of the things that I enjoyed the most, just personally, is using the robotic tool for
Mm.
surgery. We have that the ability to operate on patients with minimally invasive incisions with a 3D camera, wristed instruments, which help us to do very delicate and technically challenging work. But it's the least physical impact on the patient. And I find that also really quite awe inspiring and rewarding to see the patients do well afterward.
That's really fascinating. I think in my own personal experience, I've only seen it once in my life, but I really think that it's such an awesome tool. It's very much interesting, especially since just the idea of robotics and, like you said, that actual tool and just anatomy as a whole. It's very interesting, and we are all intricate as human beings. But I really do find it fascinating that there is technology in healthcare that is advanced, that's able to help patients that are experiencing lung cancer. Um, in terms of like recovery, what's the average sort of general rule of thumb after you've completed your surgical procedure?
So the procedures themselves are what's called inpatient procedures. So patients always have to be admitted to the hospital afterwards. Um, they typically last a few hours, the procedure themselves, and the patient comes out of the operating room with a drainage tube in the chest, draining out fluid and any air that's escaping from the lung. Just
Mm,
like any cut that can have some fluid draining, the lung itself is connected to your airway, so it can also have air leaking out. So we have a drainage tube in there, and during the time in the hospital, that typically seals and heals well.
mm,
During the time in the hospital, which is typically somewhere between 2 and 5 days of hospital stay, the patient is given pain medication, regular food to eat. They are encouraged to walk around, to do deep breathing and coughing. And then once the lung heals, so that we can take that drainage tube out, they can go home around that
mm,
2 to 5 day period. Most patients do not need to go home with oxygen or go to rehab, but depending on their health before surgery and any
sure.
complications that may come up, sometimes they do need a temporary oxygen at home or to go to
Mm,
rehab for more physical therapy to get back on their feet. Typically, patients are able to get back to work somewhere between 2 and 3 weeks after surgery, depending on
okay.
the kind of work that they do and their eagerness to get back to work.
Right,
Um,
of course.
so, um, Sometimes patients do have some discomfort in their chest wall a little bit longer, I've found, than some abdominal surgeries just because of the nerves that are
Mm,
impacted from the surgery. And usually that resolves within 4 to 6 weeks after surgery. Most of the time, though, patients only need to take the stronger pain medicine for a couple of weeks after surgery. So it's kind of a multi-step recovery process, and I encourage patients that they may even feel some achiness even longer, and that's not uncommon. Um, Also, what I found with people having major surgery is they can still feel a little bit tired or even a little down emotionally for up to 3 months after surgery. And that's not uncommon, even for other kinds of surgery. So it's something to understand and to give yourself a break, to sort of expect that it's a longer process. Even though you have these tiny incisions, your body's doing a lot of work to heal and to recover, as well as to adjust to the idea that you've had a life-threatening disease such as cancer, which has a mental impact. And so that sometimes can take a longer period of time to adjust to than your body needs to heal.
Absolutely, absolutely. I think that that's, there's a lot of emotional, mental, physical. I do think it's a trifecta in terms of, the human being having to have that diagnosis of lung cancer. So I'm going to recap a bit here. I was checking to see if there's any questions. I did not see anything, but I wanted to recap in terms of how do we reach you? I know that one of the, criteria that would be great to have coming into the office would be, as we said, that low dose CAT scan screening, if they've done that, their PET scan, if they have, other reports and images, but images is very important.
Right.
And then there's also some, if they had an MRI done, that's great, but it's not fully required because I heard you're going to order that too. And
Mhm.
then, is there anything else within that that they would, the patient or their referring physician would need to, make sure that they come in, you know, fully prepared?
Right. So it's helpful always to have a referral, especially depending on your insurance company. But having your medical records as far as your basic health conditions and any medications that you take, um, the images from your workup and evaluation of the nodule or mass. I'm happy to see people even if they haven't had a biopsy. As long as we can look at the images, we can decide what the next steps ought to be, even if the next steps are to repeat the images in 3 to 6 months if we just need to watch them. So that imaging is very important. And as far as, coming in with a potential cancer diagnosis, it's always helpful to come with a family member or a friend who can help you absorb some of the information. Just like our conversation today has had sort of a lot of layers and there's a lot of details, it can be very overwhelming to patients to come and hear about some of this for the first time and take big steps toward more assessment and treatment. So family members can be, the note takers and just a second set of ears.
Absolutely, absolutely. I mean, that's a very big decision to make, or just, just to hear. I agree with that. Any family member that can help you. I Any patient portals that for us that are sort of the digitized patients that like digital access and so on. It's not uncommon. There's lots of offices that have patient portal.
We
What do you have?
we do have a patient portal. Currently, we're using a patient portal called Patient Ally, and
Mhm.
what you would need to do is request to um, for us to send you an invitation. And then at that point, you can enter your information through the patient portal into for our office. We are relatively flexible to see patients multiple days of the week. And so we're able to see patients both in person as well as through telemedicine. So um, we're working to be as accessible as possible so that care doesn't get delayed, especially for some of these more concerning diagnoses.
Now, do you have one location or two locations? I think you have two locations. Is that correct?
Right. I'm seeing patients at multiple hospitals, and in the office, I'm seeing people in Fort Washington at 19 Shelley Lane, as well as in Darby, which is at 1503 Lansdowne Avenue, which is across the street from Mercy Fitzgerald Hospital. I'm operating right now at Mercy Fitzgerald Hospital, at Nazareth Hospital, and at Grandview Hospital up in Percy. So whichever hospital fits the patient's location and preference more is fine with me. We do
Great.
have one central office though, so only one number and fax number to send documents and to call for information. So that should be helpful. And if patients are want to send an email, we can also take emails at lumiri at support.com. No, excuse me,
Perfect.
support at lumiri.com.
Got it. Got
Right.
it. So, is there a telephone number? What I'd like to do, after we have this session, I thank you so much for coming today, and I've learned a lot. And as a lifelong learner, I'm always geeking out when things are something that I can learn. I will plug in that information for you, the telephone number, and I think we have, and you said support@lumiri.com. Is that correct?
Correct. Yes.
Excellent. All right. Well, Dr. Schatz, thank you so much.
Thank
I hope that, again, as National Lung Cancer Month, we learned a whole lot. Thank you for that information.
My pleasure.
Any of the referring physicians out there, also, just patients themselves, please, give Dr. Schatz a call if there's any questions you may have. All right. Well, thank you again. It's a short week. Have a great Thanksgiving,
Yes.
and thank you for your time.
My pleasure.
Take care.
Bye.
Bye-bye.